Good morning, everyone. This morning I was speaking about the management of spinal cord injuries, and I'd like to start off with a quote by Professor Charles Tater, who's a neurosurgeon from Toronto, Canada, and he set up a laboratory in the 1970s, which was one of the first basic science laboratories investigating spinal cord injuries. He says, the early management of a patient with an acute spinal cord injury is one of the most difficult tasks in a trauma case. During the first few days after an acute cord injury, every physician, nurse or paramedical person coming in contact with the cord injured patient bears a major responsibility. This is the most recent data that I could find from the Australian Spinal Cord Registry from 2007 and 2008, where they recorded 362 new cases of spinal cord injury across 6 national spinal cord units. And I had a little bit of trouble finding out about the spinal cord units in Victoria, but I think there's only one, which is the Austin Spinal Cord Unit. However, the Alfred obviously sees a number of patients who have spinal cord injuries associated with trauma as well. Over this period of time, they recorded 79% of which were traumatic, 46% of that as 100% being transport related, and 28% due to falls, and they had a variety of other causes. And the 21% non-traumatic causes include conditions such as spinal cord stenosis, vascular disorders, epidural hematomas, cancer, myelitis, all causing acute spinal cord injury. And you can see that the predominance of age groups are a large number of patients were a very young age group, and then sort of fairly evenly distributed across the remainder of the age groups. And males having a much higher predominance than females. This is data about the discharge neurological level, and just to remind you that the so-called neurological level is the last normal level of spinal cord function. And so we can see that there's a very high number of C4 spinal cord injuries, whether that's incomplete or complete syndrome. And then there's also a sort of a rise down here in the upper lumbar spine. Again, this is data from 2007, 2008. So I'll firstly speak about the injuries associated with cervical spine injury. And so in the cervical spine, there's a number of causes. You can remember the Jefferson's type fracture, where you get an anterior or posterior arch of C1 injury. Odontoid process injuries, which these are much less likely to cause a major spinal cord injury. The Hangman's fracture, pars interarticularis injury, as well as other injuries of the cervical spine, including atlanto-occipital dissociation, and of course the other soft tissue injuries, which I'll speak about in a moment. Of the thoraco-lumbar spine, so this is the soft tissue type of injury, where we can see the so-called teardrop fracture. Here it's C2, 3, 4, 5, 6 level. And the teardrop fracture is when you see a very small fragment of bone associated with MRI findings of much greater problems. Here we can see some spinal canal stenosis with maybe some congenital narrowing, but also some vertebral body edema. And I think the comment on this report was there was also some high signal in the posterior elements of the cervical spine. In the thoraco-lumbar spine, there are a multitude of other bony injuries. These are diagrams from the Dennis paper from 1983. And Dennis was a surgeon who described the 3-column concept of the spine, most particularly in the thoraco-lumbar spine, where injuries or fractures could be described as anterior vertebral body, middle column, which is the posterior third of the vertebral body up to the facet joints, and then the posterior column, which is more of the posterior elements, including the interspinous ligaments and the ligaments surrounding the facet joints. And so here we can see a rotational type thoraco-lumbar injury, where a rotational fracture dislocation has occurred. This is actually a picture from Royal Melbourne from last year, where this is a 3-column compression type injury, where we can see a burst element with retropulsion of the part of the vertebral body, and also a significant loss of height at the L2 level, and also a split, sort of a sagittal split through the posterior elements of the that level. So it's a 3-column unstable compression fracture. And up at the very top, this is a chance type injury where you get a flexion destruction type problem, often due to sort of a seat belt, which is thought to be, so if we consider this to be the anterior part, the vertebral bodies, posterior part of the vertebrae, and then a seat belt at the very front of the spine would cause this sort of levering of the and opening of the spine at that level, and with tearing of other ligaments or bony parts. And this one here is a anterior dislocation of the facet joints, which Dennis has also described, and that can occur at thoraco-lumbar spine levels. Speaking about the types of cord injuries, so going away from fracture, but the type of cord injury that can occur. Cord injuries can be from a variety of different types of problems: compression, laceration, shear type injuries, destruction or impaction of the spinal cord. And this is a diagram from AO, and it's their spinal cord classification. You can see that, as a lot of AO classifications, there's a quite detailed description of the exact fracture patterns, where we can see some of those shear and compression type injuries and how they might occur as a mechanism. So just also to comment, so in the primary injury of spinal cord, if we think about injury occurring at the time of the event, primary cell death happens at this time, and it's due to direct mechanical forces that are applied to the spinal cord, which cause some structural disruption of those spinal cord elements, so neuronal elements, glial, vascular structures, and therefore you get immediate cell death at the time of the injury. And this is the primary insult, or the primary injury to the spinal cord. These are just some diagrams about histological findings, and these are obviously cadaveric specimens, because you can't just transect a spine and examine it. This is a patient who obviously died at day 0, where we can see some petechial type hemorrhages of the spinal cord, and then a different patient, obviously, who died at day 3, where we can see some medullary type hemorrhages developing. And so this is just to show the vascular type problems that can occur with the primary injury. And a lot of discussion is around the secondary injury, which occurs to the spinal cord. And this is the body's response to the initial injury, which is a cascade of cellular events which perpetuate and can actually extend the spinal cord injury. And this is something which is therapies that we institute really address. So it can happens within minutes of the primary injury, and it can lead to delayed or secondary death that can actually evolve over days to weeks. There's a toxic milieu of inflammatory cytokines, free radicals, and obviously edema developing with vascular insult. At a later stage, we can see the microglial structures forming a scar, and that scar can actually cause a barrier to the regrowth of some of those neurons, so a physical fibrotic scar. There are also factors such as proteins which are released, and they can actually also deflect axonal growth away from the zone of injury. It's interesting to note that laboratory studies suggest that the secondary injury may only account for about 10% of the permanent disability, and animal studies have shown that recovery of even up to about 10% of function from the secondary injury can actually help with locomotion. So it can actually make a big difference to the outcome of the patient. Histology slides have described a number of phases occurring immediately in 1 to 2 hours, where there's obviously tears and compression with the primary injury, but also the bleeding associated with congestion and vasodilatation. The acute phase, which occurs in the first couple of days, where that edema perpetuates and there's more inflammatory changes and the protective structures, the myelin changes around the spine. And then following is the glial scar, which can occur, which occurs in days to weeks after the injury. And then over the late phase, you can get other problems such as syrinx formation, schwannosis, and again, that glial scar developing. And this is a photomicrograph of a patient at 3 months, where we can see a lot of that necrosis developing, and these black arrows are pointing to areas of necrosis. So moving back on to assessment of a spinal cord injury patient. So obviously in the trauma setting we have to consider EMST principles, in particular considering other injuries that patients may occur, including thoraco-lumbar injuries, thoraco-abdominal injuries, as well as head injuries, and obviously in the cervical spine there's a high incidence of traumatic brain injury as well.
consider the mechanism behind the injury, so the amount of energy which has been transmitted to the spine, and of course documenting a full neurological examination. So in the acute management of EMST, the first step is applying cervical spine, and we have to make sure that the cervical spine collar is well fitted. So this is a Philly type collar where the Velcro straps must be evenly distributed on each side, and its anterior part should not be flared. I'm sure you've seen many patients with a Philly collar which fits above their mouth or over their ears and all these strange things that people fit. And so there's some nursing guidelines on the OrthoFracs website about the correct fit. In some circumstances, say with a rotational injury or a dislocation type injury, some gentle traction may be provided to the spine, so that's the Gardner-Wells tongs. That's actually more of a later therapy rather than sort of an acute phase. But also about maintaining thoraco-lumbar spinal precautions in someone who is suspicious of a thoracic or lumbar spine injury, and that's immobilization on a neutral surface, in a neutral position on a flat surface. Obviously, if patients have associated head injuries and the head needs to be raised, the neurosurgery and managing that area, then the whole bed needs to be tilted, not obviously tilting at the hips. And this is, I don't think Western Health has one of these, but it looks pretty cool. So we can have some funding to do that. I don't know, I've got no idea what delta kinetic means, but anyway, it provides a lot of options. So examinations. So in someone with any major trauma patient with who has come in, EMST principals, we do a log roll to look at their spine. And if that's an intubated patient, then we need to be very careful about examining for some of these subtle signs of spine cord injury. Obviously, in an awake patient, we would be examining for tenderness as well. But things such as step-offs, so feeling carefully down against the spinous processes, feeling for any step-offs, obviously bruising, and interspinous widening as a sort of a different concept to step-offs. The traditional grading system is called the Frankel score, and this was popularized in the 1970s by Frankel, but actually was produced back in the 1930s. And it's just describing the completeness of spinal cord injury. It's been critiqued, it's been replaced since then by the Asia score, which I'll speak about in a second. But part of the critiques of the Frankel score is the subjective element that differentiates grade C and D, where the clinician is the one who's making the call about function versus non-functional motor abilities. And also the fact that grade D is really talking about lower limb function rather than upper limb. So say a cervical spine injured patient who might have good hand or arm function is not well documented in the Frankel score. But just to note that this is, again, grade A, a complete neurological spinal cord injury, versus grade E, a normal motor function, and the grades in between. And that actually corresponds to the new Asia score, which the next slide will show you, again, the grades A to E. But the Asia score has been produced more recently and is really a thorough documentation of the neurological injury with the spinal cord injury. And so it's using the MRC, Medical Research Council grades of injury, so from grade 0 total paralysis to with or without gravity eliminated, and then grade 5 being full power. And then you document every level of the spinal cord. And so it's really quite thorough, right and left sides. And then come up with the score down the bottom. And then sensations also documented, with 0 being absent, 1 impaired or 2 normal sensory function, and then obviously in the intubated patient, not testable. And so then this is a summary of the insult, and then that can actually be measured on successive times to document the patient's recovery. And so this is a bit blurry, but this is just a further discussion about how you calculate the Asia score. So you're determining the motor and sensory levels of each side, determine if there's a single neurological level, so the last normal level, and then is the injury complete or incomplete, and that's really about the level of sag plus sparing. And they talk about here voluntary anal contraction, whether it's present or not, and anal sensation. And if both of those are not, if
either of those are present, then the injury is incomplete. And then we can go on to talk about how you classify those as A, B, C, or D, depending on whether it's motor incomplete or sensory incomplete. And again, the grades A to E is similar to the Fraenkel scale. This is really hard to see, sorry, but this is the Royal Melbourne Hospital Trauma Service investigations guideline, where they describe a patient with a possible cervical spine injury, and then they apply the nexus criteria, which are more for CT scans of the head, which describe posterior midline tenderness, reduction in conscious state, intoxication or distracting injury, or do they have a focal and neurological deficit. If they have any of those findings, then you should do a CT scan of the head and neck. If they do not have any of those, then you can examine them properly and potentially take the collar off. When we do and the other thing with the CT scan is about the energy of the original mechanism. So was there another death at the scene? So say a motor vehicle accident, which is obviously a high energy. Is the combined velocity of each vehicle more than 60 kilometers an hour? Or is there another major distracting injury similar to the first part? And in fact, if none of those are present, you may even skip the CT scan and just go straight to plain films. In saying that, my experience at Royal Melbourne last year is that everyone gets a hand scan, CT head, neck, chest, abdomen, pelvis, in a high energy mechanism. And really, it's quite rare to get plain films of the neck. There are low thresholds for getting CT necks. And this is the Royal Melbourne Thoraco-lumbar spinal guidelines. Again, talking about whether there's high risk factors, so they've identified a cervical spine fracture, and saying that obviously you would prefer to do the full CT at the same time, chest, abdo, pelvis. Are there any sort of clinical features such as midline steps or hematomas that I spoke about before? And then it helps you decide about whether you continue on to get a CT scan or plain films. Just another factor, a patient with any past history of spondylosis, ankyspon or dish is at much higher risk of having a spinal cord fracture, even with plain films being you can't see any fracture on plain films. And therefore in these patients it's important to investigate it further with a CT scan or MRI or bone scan even to investigate for fracture. In particular, ankyspon has been documented to have 11.4 times greater risk than the normal population of having a spine fracture with trauma. And obviously with any of these injuries, because they're so well strutted with a stiff spine, they can initially be undisplaced, but later displaced to lead to delayed cord injury. I'll just speak briefly about the clinical syndromes and just about how they affect the cord. So central cord syndrome is affecting the central cord as such, and this is the anterior part of the spine, the posterior part. Whereas brown saccade is a hemisection of the spinal cord, much lower incidence. The anterior cord syndrome, which is again more lower incidence again, and the posterior cord just affecting the sensory elements of the back. And then the Conus medullaris syndrome, where the cell bodies of L5 to S4 at the T12 to L2 level, so right at the bottom of the cone, the spinal cord, are injured, and it can actually present with upper and lower neurological signs. And obviously the Thoraco-lumbar syndrome, where compression is occurring in the lumbar or sacral spine, causing injury to the spinal roots. So that would be lower neurological signs. Just a brief mention about stingers and burners, and there's not very much literature or good evidence that I could look up, but a stinger is a type of transient neurological paresis, where a patient can experience pain or electrical sensations that radiate down a single limb, usually the arms, following an injury such as a football or even a sports injury. It's described as a peripheral nerve injury, so it's due to traction or often due to traction. And the duration of the symptoms can last from a few minutes to a couple of days, and it would be quite hard to manage this patient or to monitor them in a sense if it's persisting for a couple of days. You know, where do you draw the line about investigating further with an MRI scan in these patients?
multi-limb involvement should be further investigated, and obviously with any of these patients you need to do a full neurological examination. And often a problem when managing these patients is when can they actually return to sport with this transient paresis problem without any obvious structural problem with the spinal cord. There's also this syndrome of spinal cord injury without radiological abnormality, which is without abnormality on X-ray or CT scan, and it's later identified on MRI if you've got abnormal neurological findings. And this is a problem often more of the pediatric population, which can occur in sports and also in child abuse. Okay, so with obviously with the neurological deficit in spinal cord injury is the primary problem, but we have to, in the unstable trauma patient, we have to consider other causes of their lack of neurological function. So hypovolemic shock, obviously with other injuries, may be due to the primary injury with hemorrhagic shock, or it may be due to a lack of resuscitation in the trauma patient. In fact, there's well-documented evidence of greater improved neurological outcomes with early management of supranormal mean arterial pressure, supranormal being 85 millimeters of mercury or greater. Spinal shock, it's hard to differentiate between spinal shock and neurogenic shock from what I could read, but neurogenic shock is more likely to occur with cervical or high thoracic spinal cord injury, and it's really due to disruption of sympathetic fibers, which exit the cord at these levels, and therefore you get unopposed parasympathetic outflow, which can then lead to hypertension and cardiac arrhythmias. And this is due to arteriolar dilatation, pooling of blood in the venous compartment, and therefore a patient with a low cardiac output. And it's important to manage these patients in an intensive care setting with both inotropes and chronotropes to improve contractility as well as heart rate. And these problems can actually persist for up to a couple of years. And so sometimes a pacemaker might be needed to maintain good cardiac function. Some guidelines that I've also read noted the importance of monitoring patients' temperatures, and particularly this regarding sympathetic tone with high thoracic or cervical injuries, that there can be altered thermoregulation of vasomotor control, and patients can get this poikilothermia, where the body can assume the temperature of the surrounding environment, and this can actually persist for years after the injury. I'm not sure how you manage that in a chronic sense, but it demonstrates the importance of bear huggers or cooling mechanisms to help manage these patients. So in terms of the medical side of managing a spinal cord patient, there's this article from 2006 in the Spinal Journal by a neurosurgeon called Herbert, and he was actually commenting on a couple of other studies in the past, known as the NASCAS trials, which I'll speak about in a second. But he was critiquing those studies and also looking at other emergent therapies in spinal cord injury, such as this GM1 ganglioside and other factors which can be neuroprotective, as well as stem cell transplantation. So these are all things that potentially may be available to us in the future, but I'm not aware of whether they're actually used routinely in spinal cord units. So Herbert was commenting on the NASCAS trials, which were three very large multi-center trials from the 80s and 90s by the main author being Bracken, and they were really investigating methylprednisolone and the use of steroids in the acute patient. And the first trial was regarding the dosage of methylprednisolone, so 100 versus 1,000 milligrams, which was given on day one and then maintained for 10 days after the injury. And then later discussing against a dose of 30 milligrams per kilo versus naloxone therapy, and then about timing and duration. So the 1984 paper had 330 patients involved in it. It was a randomized control study, and they found that there was no difference between 100 milligrams and 1,000 milligrams dosage, no difference in neurological outcomes, both at 6 weeks and at 6 months. Despite that, they also found that there was a much greater rate of wound infection at the trauma sites and also the operative sites, and an increased rate of early fatalities in the higher dose steroid group, in saying that the fatalities were not statistically significant. It's interesting, however, that they continued on with the 1990 paper, where they used a 30 milligram per kilo dose, and say a 50 kilogram mouse is 300, so then it's about sort of 450 for a 70 kilo male. So it's still a high dose of methylprednisolone, despite the complications that they found in the 84 paper. So that was the dosage. And in this study, they enrolled 162 patients in the methylprednisolone group, 154 patients in naloxone, and then they had a placebo group as well of 170 patients. And they found that there was no difference in naloxone versus placebo treatment in spinal cord function and neurological function at 6 months. However, they did find that in the group which was treated within 8 hours of the injury, there was an improved neurological function at 6 months. And that led to their later study in 1997, which trialled the methylprednisolone use in the first 24 hours versus the first 48 hours, where patients would receive a bolus dose and then an infusion of methylprednisolone for either 1 day or 2 days, and they compared that with another medication, tirolazad, and they found that there was no real difference in the two groups. However, subgroup analysis, they recommended that patients who received an initial bolus within 3 hours of the injury, that should be maintained for 24 hours. But if the initial bolus is between 3 hours and 8 hours, then the prednisolone should be maintained for 48 hours. And that was their recommendations. In saying that, I asked for the registrars at the hospital, and they don't actually use steroids there at all. So despite these recommendations of Bracken, and that's probably something which has come out of a later paper in 2006. This comment was in one of the guidelines that I read, that steroids should not be used more than 8 hours post-spinal cord injury, despite this ongoing infusion that Bracken's recommending, nor in the setting of trauma, open wounds such as gunshot wounds. So, and Helbert in 2006, in critiquing these NASCAS trials, comments that steroid use in current day-to-day practice is really out of peer pressure and fear of litigation about what might not improve if we don't use steroids. But he really reinforces the point that there's a high rate of complications with these patients. The CRASH trial was not investigating spine injuries, but it can be related. It was corticosteroid randomization after significant head injury. And it was a trial from 2004, which aimed to investigate 20,000 patients, but they actually only collected 10,000 because it was terminated early. And they were collecting data on patients with head trauma, Glasgow Coma scores of 14 or less, that were caught within 8 hours of the injury, and they randomized them to either corticosteroid use or placebo. And they found that in the corticosteroid group, when they analysed, actually collected quite a lot of data before ceasing the trial, that there was a much higher rate of fatality in the corticosteroid group than the placebo group. And it was aborted prior to completion. So again, commenting about the complications of steroid use in neurological injured patients. Moving on to also surgical discussion about these, about indication for surgical treatment. This is a trial from 2002 from the Journal of Trauma, which is about the use of operative spinal cord decompression in a cervical spine injured patients, where 91 patients were enrolled and prospectively investigated for. They were enrolled where 91 patients were divided either into a protocol group, which was 66 patients, or the reference group, which was 25 patients. And the reference group were patients who had contraindications to MRIs, had another procedure for acute trauma, or the treating surgeon decided not to operate or not to proceed with the MRI investigation because they didn't believe in it.
whereas the protocol group all had an emergency MRI scan followed by surgical decompression in 46% of cases. And they found that early surgical decompression with MRI findings improved Frankel grade by 1 grade in 50% of cases, whereas patients who were managed in the reference group who had, in that sense, delayed MRI or delayed procedures, only 24% of them improved in 1 Frankel grade. So it's, this study is reinforcing the use of early MRI to investigate these patients with or without spinal cord decompression. And further about the thoraco-lumbar, the guidelines for surgery. This is, I think Amy spoke about this recently, but it's the Vicaro's TLIC score, where the injury morphology, the neurological status, and in particular the posterior ligamentous aspects of the spinal cord used to help us decide whether to proceed to operative intervention. This is not so much relevant to spinal cord injury, however. As just a final comment, in the spinal cord injured patient, it's important to consider other factors, such as because these patients are often lying around for a long period of time, so the importance of pressure care management, where pressure sores actually occur in 30 to 50% of injured patients. Sacral areas are most common, and they're the ones that actually often need the flap reconstructions. And the healing of these, when they're discovered, the treatment and healing can actually take quite a long time, and it can significantly delay the spinal cord rehabilitation for these patients. Also being aware of the importance of collar care in the first few days after the trauma, particularly with the amount of swelling that these patients can have. The Alfred also describes in their trauma guidelines the log rolling technique, and that 4 persons need to be present to properly log roll a person to safely do that. 1 for the head, 2 to manage the torso and limbs, and the 4th person for the necessary procedure, whether it's cleaning or examining or carrying out another sort of procedure. And of course the importance of sideline patients for chest physiotherapy to help balance the lungs and redistribute fluid. And this is obviously something which needs to be done in consultation with the spinal management service, or the neurosurgical or orthopedics team, about whether that's permissible or not based on the patient's injury. This is just an X-ray from a patient that I saw in Royal Melbourne in the trauma bays, and they had a complete paraplegia below this level, and we had to refer them straight on from ED to the Austin. And, I think it was after a water skiing injury up in Mildura, and they were transferred down a few hours after the injury, so I never found out what happened. Pretty dramatic X-ray, CT.